G'day everyone, it's Brett here for the latest edition of Infection Control Matters, and Martin's with me to have a chat. G'day Martin.
Hello, Brett. On the other side of the world, as usual.
Yes indeed. And it's nice to be able to chat to you because I think it's been a little while since we've done one together, so it's good. And actually, before we get going, we put out a little message or two the last day. We cracked 100,000 listens from our podcast, and I think it was 110 countries in the last, I can't remember if it was 6 months or 12 months now that I look at the stats. But anyway, a lot of countries and a lot of listens. So thank you to everyone for listening to us rabbit on about infection control stuff.
Yeah, I think it's fair to say we're pretty shocked that we got to 100,000 and that we still got the stamina and for the enjoyment of it. But over 100, nearly 160 countries in total since we started 3 years ago. So
is there that many countries in the world? Is there? Wow.
Yeah.
I'd also say thanks for the comments because and feedback we get, because sometimes we wonder if anyone's listening, but also it's a fair bit of work that goes into this, and particularly thanks to Martin over the last couple of months because you've been pumping them out whilst I've been a bit busy. So thanks for the comments that come in too, because when we get those comments, we know people want to listen, and that's good for us because we'll keep doing them.
It's really nice when somebody comes up to you at a meeting and says, I've enjoyed that one, or I've met someone, or, it's nice feedback. So keep it coming.
And I think we've got a live, is it a live one coming up at the IPS conference?
Yes, we're going to do Infection Prevention Control Matters live on stage.
I'm not really sure what that's going to look like yet. No, that's too big.
As usual, we're going to do our usual huge amounts of preparation.
Yeah. Look, I reckon we'll have something prepared for that. We'll have to. But, Okay, anyway, let's crack on, Martin. Today's paper that we want to talk about.
Yeah, so it's actually one of yours. Yeah, it's one of yours. And that's the reason for it is that just about every meeting I go to, and I was fortunate enough to go to the APSIC meeting recently in Jakarta, and Gonzalo Bierman gave his usual very, very nice talk about contact precautions and are they necessary. And then there's a big discussion going on from the audience, and we've had a few podcasts on this subject about getting rid of gloves and aprons, and I'll list them in the blurb on this podcast in case anybody's missed them in the past. And you published a paper in Clinical Microbiology and Infection, which is the ESCMID journal. Now, interestingly, that journal often has a commentary about what study do we need, and they're always about a drug. But this is the first one I've seen about infection prevention. So this one's about contact precautions, designing the ideal study.
It is. And before I get going, I'd say, look, Sarah Browning is the lead author and really led and drove this piece of work. So I want to give full credit to Sarah. And Josh Davies, one of the authors as well, came up with the idea that CMI were doing this. What do we need? What trial do we need? And we thought, why don't we do one for infection control?
Well, actually, you could probably fill that commentary for about the next 10 years. Infection control.
We could actually have a regular segment on infection control matters about
what study do we need?
And I guess this all started because of this idea that do we need gloves and gowns for contact precautions, specifically for VRE and MRSA? Now, you could extend this out to other pathogens potentially, but there are, of course, other transmission dynamics at play potentially for other pathogens as well. So deliberately wanted to do it for this. And I guess, the guidelines around the world, by and large, still talk about contact precautions for these pathogens. Some hospitals have moved away from using gloves and or gowns. And so I guess where we were coming from is the real need to do an RCT to answer this question once and for all. And there's a few reasons why we thought that was necessary. There was a systematic review conducted looking at the evidence around gloves and gown use for MRSA and VRE. And it consisted of, I think it was 17 or so non-randomized trials. And one of the problems with non-randomized studies is the inherent bias that is introduced. And we've seen in other literature where observational studies, quasi-experimental, basically non-randomized controlled trials have said one thing. Then there's been RCTs conducted and they've shown the complete opposite.
Yeah.
And so I guess where we're coming from is there's a win either way with doing this trial, because if the trial suggests we do need gloves and gowns, well then great, we should stop the hemorrhage of hospitals perhaps that are moving away from it and potentially therefore causing harm to patients. On the flip side, if we don't need them, then that's great for also a large number of reasons, including environmental and sustainability reasons, but also, trying to comply with hand hygiene when you're in contact precautions and the 5 moments of hand hygiene is actually quite difficult to do. So if we can remove some of these burdens for healthcare workers, then we may see a better uptake and ability to apply other infection control practices appropriately. So I guess that's the reason why we wanted to tackle this.
Now, in picking MRSA and VRE, and knowing that there are other pathogens available, it sort of implies that we're completely confident that we know the transmission pathways of MRSA and VRE. Are you completely confident we know the transmission pathways of those?
Oh, look, I don't think you can be completely confident about any transmission pathway. And I don't think there are, I think it would be unwise to suggest that there's only one transmission pathway for any particular pathogen. But let's just assume that contact through the environment, direct or indirect, plays a significant or an important transmission pathway, not the only, for these pathogens. So how confident are we? Well, I guess the flip side to answer that without actually answering the question would be to say, well, the guidelines out there, I know. I've got that ability to answer a question with a question. To flip that around, you say, well, all the guidelines around the world, by and large, recommend us doing this, right? Using gloves and gowns for MRSA and VRE. So if they're recommending it, are they not based on evidence?
No. In my experience, they're based on historical. It seemed like a good idea at the time. Evidence.
Yeah.
I mean, I'm going to help you out here.
I was going to provide some support for that justification.
No, I was going to help you out here because actually, one of my papers of the year when I presented at APSIC was Kalisvar's Maridamousu's paper on, clonal and plasmid transmission, and generally, MRSA and VRE it's just clonal problems. And you can do something about that. His study showed you can actually do something about those with more traditional infection prevention methods, which is what I'm going to class as contact precautions. Whereas all the gram negatives that are spread by plasmids, that doesn't really work for that. So I think probably you are right in just narrowing down. I was just being a little bit.
No, it's a good question. It's a good question because I don't think we can. I think we always need to be challenged on all these points. Actually, speaking of which, with the APSICOMs, we must have a chat about your top 10 papers at some point. But was it top 10 papers?
It was a bit left field. Yeah, it was top 10 in 2022, 2023. It was a little bit left field in places.
Okay. But I think the other reason why VRE, MRSA, you could say, okay, do you think the pathways are significant by the contact rate? I guess from a survival and environment point of view, we know these pathogens survive for long periods of time, therefore have the potential to be they are inviable, so therefore have the potential for ongoing reservoir for ongoing transmission.
Yeah.
We know from systematic reviews and meta-analysis of prior room occupancy risk related particularly to particularly to MRSA. VRE is a bit more of a mixed bag in those systematic reviews when the meta-analysis was done. But then if you look at the RCTs that are around cleaning that have been done, and Deb Anderson's study, the REACH study, both showed reductions in VRE when cleaning was improved. So if you assume that those studies, those findings hold true, then you'd say the environment's an important source, therefore contact, indirect and direct would be an important source. Anyway, have I convinced you on that one, man?
Yeah, you have. Well,
and I think your reference to Callis's papers is a good one too. Actually.
Okay, so how did you go about designing a study then? Because this is a theoretical study. You haven't got funding.
This is a theoretical. No, we haven't. We're hoping to, and we're aiming to to think about putting in some grant applications over the next little while. This will be a big study. And if you're a listener out there interested in participating, we are looking for both Australian sites, potentially New Zealand, UK, and Canada. So anyway, that's by the by. But we had to consider so many things when we were thinking about how would you design this, because it kind of needs to be pragmatic. It needs to be pragmatic because you're going to need a lot of hospitals because these infections are relatively rare. We need to think of what is the outcome we're most interested in. We talked about VRE, MRSA, but what do we mean by that? Are we talking colonization, which can be influenced by screening and various other things? Are we talking about sterile sites, bacteremias, of which, they're really quite relatively rare when we're talking about trying to design a study? So we had to think about all those types of things. How are we going to think about different screening policies between hospitals and practices? Single rooms versus hospitals that are larger rooms. The list goes on, and so you could see why this hasn't been done before.
I mean, do you make the point about single rooms? Because placement is always, if you read the list of contact precautions, it normally starts off firstly. First one is placement of the patient.
That's right.
They go into a single room, or they get cohorted with other people.
Yeah.
And your design it's not about removing contact precautions per se. It's about removing gloves and aprons. So you would still use the usual patient placement.
We would.
Because a lot of people are under the impression we don't need to isolate them anymore, and that's not what you're saying, is it?
No. What we're saying is you keep your existing practice, whatever that might be.
Mm-hmm.
And of course, and actually going back to that meta-analysis of non-randomized controlled studies that shows no difference when you use gloves or don't use gloves. A lot of those studies are actually in the US, where there are also high proportion of single rooms, if not all single rooms.
Did they actually say in those studies what the actual makeup of the hospital was?
Well, that's the problem. They don't. And I think we can assume that, make some assumptions around that, but that would have been really helpful to know. We have to think about all those things and, what could be collected pragmatically for a data collection. So we're not asking people to do more and all those kind of things. So we sort of ended up in the end of having the effect. Our proposed outcome was to look at both the incidence of MRSA and or VRE from clinically collected and routine specimens. I kind of figure that so long as the hospital doesn't change their screening practices throughout the study, then that would be relatively constant for them throughout that individual study. And going back a step, I guess what we proposed was as a cluster randomized controlled trial. So where you have a large number of hospitals, they all start in a control phase. And then a proportion of those hospitals switch to the intervention, which would be the removal of gloves and gowns for contact precautions. The rest of the hospitals remain in the control phase. So if you imagine like a square and it's divided into four, and the left-hand side, you've got everyone in a control, and as you move to the right, just the bottom right-hand corner of hospitals move into the intervention phase. And we figured that, great work from Nicole White, who's a statistician helping us with this. And we do realize it needs to be not only just a lot of hospitals, but also a long time. So this study would need to be undertaken over 2 years and have 50 hospitals involved in it. So the plan really would be to do this cluster RCT, have those outcomes that I mentioned, have some secondary outcomes around gown and glove consumption, estimated tons of landfill and CO2 generated, sterile sites for VRE and MRSA, and have some mixed adjusted sort of mortality secondary outcomes as well. So,
and you can get some good financial data on those aspects as well, couldn't you?
We can. I think
just about the actual tonnage, it's cost saved as well.
That's right, because it's the reduction in actual purchasing and also subsequent reduction of having to either incinerate, depending on what the wastage, what the policy is.
See if the consumption of soap and alcohol hand rub went up.
Yeah, it would be. It would be, wouldn't it? So, there's a lot of other things to think about in terms of, antimicrobial use and AMS programs and various things like that. So, again, that's why this sort of cluster RCT design was used to try and account for and manage some of those issues. There might be the potential to actually randomize in a stratified way as well. So you might go, okay, well, let's make sure there's similar numbers of hospitals that have similar numbers of proportion of single rooms, for example, or it might be that similar approaches to screening of MRSA and VRE. So thinking about how we could stratify the randomization process as well to make sure that even though it's 50 hospitals, it should balance out pretty similarly. But
you'd have to take into account colonization pressure as well.
Colonization pressure would be another issue. Yeah. What we're trying to do is design something that lots of hospitals could participate in with very little effort in terms of ongoing data collection, because a lot of this data would already be collected in terms of MRSA and VRE isolates. So, and some of those, of course, have integration with patient administration systems as well. So, we're trying to make this really easy for people. That's the pragmatic side, and really the assistance to come about the implementation or de-escalation of gloves and gowns and what that might look like. So I guess that's sort of it in a nutshell.
How would ethics go with this then? If a patient with MRSA is in there and the staff are 1 week coming up to them with gloves and apron on, and the next week they're not wearing anything, how are you going to sell that?
Yes. Well, actually, we've got good equipoise for this study, because what we did do was a survey across Australia. Sarah led a survey asking IPC teams and ID physicians about practices for MRSA and VRE contact precautions currently. And interestingly, some hospitals have already moved away from using VRE and MRSA. A large number of hospitals were interested in stopping gowns and gloves, and a large number of hospitals were also interested in participating in such a study. So I think we've got reasonable equipoise, and also from an ethical point of view, be able to say, okay, we've got at least a meta-analysis that says there's no difference if we remove them, with the caveats I talked about earlier. And also some hospitals are already moving away from it. So I think we can probably address that.
Do you think that the fact that we're removing gloves and aprons and people aren't getting infections, and so in these non-RCTs showing no difference, is a result of actually people's practice getting better over the last few years? People are using bundles more, so therefore they're more likely to be able to prevent these organisms getting into the bloodstream, which is what you would class as a serious infection. IV line care has got better. We look at the lines, we don't leave them in too long, we're careful about our technique, a lot better than we used to be, that's for sure.
Yeah.
And VR is similar. So do you think we are now at a position where practice has improved? It's obviously never going to be perfect, but moved to an extent where it's safe to de-escalate some of these? Because I almost look at this as debundleization. Contact precautions to me is side room gloves, aprons, environmental hygiene, etc. So if we take out two elements of the bundle, what would it matter as long as you do the others?
Yeah. And look, there's also a lot of school of thought just taking that to the next level about doing more horizontal based infection control approaches and getting away from this sort of syndrome-y type approach per se. So really making sure that your environmental cleaning is, top notch, hand hygiene, that things that make a difference in terms of skin preparation and antibiotic prophylaxis at the right time, all these sort of antiseptic use and decolonization, all these things that are really done hit and miss in across the board. Not everyone's doing everything. If we got all those things as the standard of care, hand hygiene included in that, air quality included in that, then what do we actually need to escalate to? What pathogens are really the ones we need to escalate to and concentrate on those? It might also find that then we get better, I hate using the word compliance, but better adherence to what we're asking healthcare workers to do if we're not actually asking them to do it for every second patient. It's like exaggeration, but Yeah, and you're right. I think there've been lots of advancements in other bundled areas where we're probably seeing reductions across the board. But just on cleaning for a moment, there's a great example. Well, we cleaning's not done that well, right?
No,
So
no, that's an
study after
understatement of the
study shows
decade.
that.
Yeah,
Yeah, but we
yeah,
know it works. So we can say, oh yeah, let's make these other things better and de-escalate or get rid of some of the bundles perhaps, but de-escalate some things. But we've got to actually make these other things better because it's sort of putting all your eggs in one basket if you don't. And I think
yeah.
it'd be problematic if we started de-escalating things without actually, improving some of the other things that we know work.
Do you know if some of the hospitals who've already adopted this, no gloves and aprons, have they actually stopped isolating people as well because they haven't got the capacity because they've got that many really multi-resistant gram negatives that are more concerning? So therefore, that these organisms are dropping down the priority list to the extent where actually we're almost going to have to say either they're endemic or they're not causing enough of a problem to be
Yeah,
an issue.
yeah. I don't know the exact answer to that, so I wouldn't want to speculate.
Make a nice short survey of that, wouldn't it? Have you stopped contact precautions? Are you stopping contact precautions? And by that, are you including patient placement as part of
Yeah, and
that
I'd have to go
contact
back to
precaution
look at the
bundle?
survey that we did to
Yeah,
see if we actually answered that question, asked that question.
yeah.
And I should know, but I can't think of off the top of my head whether we did or not. I guess the other, just on your other point to that is, often we don't have enough side rooms, and we probably already the lowest thing on the priority list is probably VRE and MRSA, right?
Yeah.
So if we're dealing with all these other multi-drug resistant gram negatives and some other resistant gram positives, and then on top of that, viral infections, respiratory viral infections that are around, and bacterial infections. But probably MRSA and VRE are at the bottom of that list anyway already in
Hmm.
terms of isolation. So for hospitals that only have a limited number of single rooms, 20, 30%, then, or even less, then, they're probably not isolating people anyway for MRSA and VRE. So,
Okay, so if
yeah.
they're not isolating people, should they then make sure they're using gloves and aprons because they
Yeah,
can't
that's right.
isolate them? What's
Mm,
more important, the
mm,
patient placement, separating them,
yeah,
or
yeah,
the PPE? You know,
yeah. So look, I hope I don't know the answer to that one, Martin. I'm going to avoid that
no.
question. But I think the plan will be to try and get some funding to support this and try and get this trial up at some point. As I say, I think it's a win-win regardless of whatever the result is. So
Yeah, that's true. Yeah.
it's a nice way to be with the trial. And I guess all
Probably
we got to
not
hope
that
for is,
expensive as well, either, really, is it? In
well, I
relative
mean, it will take a
terms.
few years to do, so it would require a reasonable amount of funding.
But you're not,
Certainly not going to be.
putting in a new innovation or anything like that, are you? In some ways, you're
No,
taking
I
away.
don't
So,
think we're
and
talking.
and people are already collecting this information anyway, so that would help,
No,
I would think.
I think so. So I don't think we're calling double-digit millions here. I think it's probably the lower end of the millions. So yeah, but these trials, that something might go, well, what? You're talking millions, but these
Yeah.
trials are very expensive to run. Otherwise, we're doing lots more of them.
Yeah.
So yeah, I think I would work all that out when we could submit grant application. But I think when you're collecting outcome data that people are already collecting, that does help
Hmm.
significantly with cost. Data collection is often an expensive component of a trial for
Yeah.
infection control, at least anyway. Yeah, so look, that paper is out there if anyone wants to have a read, and if people have got comments on it as well. The idea of putting it out there was to invoke discussion and see if it's right and things that haven't been thought of. So please do have a good read of the paper if you're interested, and if you can't get hold of it, let us know, because that's to say that's the point of putting these out there. And it was interesting, the reviewers when they reviewed this paper, I think there were 5 reviewers, and they were really, really detailed. They were really across the details. So we're really hoping that this adds something to people's thought about what could we do in this space.
Certainly won't hurt the grant application to know it's been
No,
already been through a peer review process and has been
yeah,
rigorously examined by a number of people. So that will
yeah,
probably
that's
help it.
true.
help refine it. Yeah.
Fingers crossed.
Okay. Well, good luck.
Thanks, man. Thank you. Thanks for chatting about that.
Okay.
One. Yeah.
Okay, everybody. Well, hope you've enjoyed this one. And as usual, we haven't answered the question as to whether you can safely remove contact precautions.
Not yet.
The truth, hopefully, is out there, and watch this space.
Maybe I've got a rich benefactor that's looking to donate a couple of $1 million. So feel free to send them our way.
Okay. Thanks for joining us, everybody. Bye bye.
Cheers, everyone. Bye bye.